Good morning, sir. Good morning, everyone. Presenting a case today. My patient, 59-year-old female housewife, resident of Ganganagar, Rajasthan, presented with chief complaints of yellowish discoloration of sclera and urine since 1 month and itching since 15 days. The patient was apparently all right 1 month ago. Then she noticed yellowish discoloration of eyes and passage of high-colored urine. It was insidious in onset, progressive in nature for 1 month, and was not preceded by any prodromal symptoms. The jaundice was associated with progressively increased generalized itching, which started from periphery to abdomen, present throughout the day, and caused sleep disturbances. Associated complaints of clay-colored stool since 10 days was also present. There was loss of appetite and unquantified loss of weight. There was no abdominal pain, fever, chills, no nausea, vomiting, hematemesis, melena, or silver paint-like stools. There is no associated fullness or lump in right upper abdomen. There is no shortness of breath or cough, no bony pain or back pain in patient. In the past history, the patient did not have any medical comorbidities. There was no history of any surgical or any medication history in the past. The patient had a vegetarian diet with no addiction of alcohol consumption or smoking. Her bowel and blood habits were unaltered. However, there was disturbed sleep due to itching. There is no family history of any malignancy or no untimely death in any younger family members. To summarize, it's a 59-year-old female with no comorbidities and no family history of malignancy, presented with complaints of progressively increasing painless jaundice for 30 days, associated with clay-colored stool, progressive pruritus, which disturbed sleep, and loss of appetite and unquantified loss of weight.
So you said no history of any prodromal symptoms.
Yes, sir.
See, prodrome is a generic term. For different diseases, prodrome may be different. So what prodrome you are talking about?
I was suspecting whether there was any fever, chills.
So you are talking about prodrome of viral hepatitis.
Yes.
So good that you asked for that, because when there is a short history of jaundice, like here it is only 1 month, it could be hepatitis also. But then when you say no prodromal symptoms, either you say no prodromal symptoms of viral hepatitis, or you specify what you exactly ask. So some examiners may accept at this stage that yes, it is presumed that you know what are the symptoms, but some examiners may insist that no, you specify. So it is better to say that there is no history of prodromal symptoms of viral hepatitis such as this. Okay. So, and second,
good morning, Kapoor sir. Happy New Year.
Rajendra sir.
Yes, Rajin.
Good morning. Happy New Year, sir.
Thank you. Same to everyone.
Yeah.
Second is that dealing with jaundice, other than the fact that whether it is progressive or intermittent, the second most important feature is whether it is pain, with pain or without pain. In your negative history, pain should have come at the top, that there is no history of pain. In the summary, you have mentioned it, but in the negative history, pain should come first, that whether there is pain or not. Because if it is jaundice with pain, and especially if jaundice is intermittent, then obviously the commonest cause is choledocholitis, CVD stone. If it is painless jaundice, if it is progressive, then you start thinking of malignancy. If it is painless intermittent, then you start thinking of benign conditions like choledochal cyst in a post-cholecystectomy chronic pancreatitis and other causes of benign biliary obstruction. Now, in malignant jaundice also, pain will be present mostly in CA head pancreas. CA head pancreas, 60 to 75% of patients will have pain with jaundice. Next comes CA gallbladder, especially if it is fundus or body growth which is infiltrating the liver, and the jaundice is caused by either nodes or some other reason, then also there will be pain. But GBC neck with jaundice may not have pain because the tumor is small. And if it is painless, then more likely to be periampullary carcinoma or a hilar cholangiocarcinoma.
Shall I proceed, sir?
Yes.
I wanted to know why you have included periampullary as the first. There is no feature in the history which supports periampullary.
Yes, sir.
Because
Patient.
you specially made a mention that there is no silver-colored stools.
Yes, sir. Yes.
Why do you get silver-colored stools in periampullary carcinoma?
Sir, it is because of the tumor sloughing which may cause melena and mixture of clay colored stool which will give it as a silver paint appearance.
Yeah, so you specifically mentioned that.
Yes.
If you have specifically mentioned that, the examiner gets the viewpoint that you're not considering periampullary carcinoma. Yet you have put that as the first differential diagnosis.
Sir, because sir,
Your diagnosis should be malignant surgical obstructive jaundice. And the commonest cause in the north is carcinoma of the gallbladder. Any patient presents with surgical obstructive jaundice, carcinoma gallbladder has to be included. Second thing is, it's a short duration history. Why is there no benign differential diagnosis in the differential diagnosis list? It could be a benign cause,
sir, because
like
considering sir,
autoimmune biliary disease. It could be sclerosing cholangitis. It could be other conditions which can cause surgical obstructive jaundice.
okay, sir.
Stone disease, Meritzi syndrome. You can't really differentiate between this and Meritzi syndrome. This could well be the story of Meritzi syndrome. But painless jaundice, I accept that you would put that as a lower priority, but it should definitely be there in your differential.
Okay, sir.
Because as the person grows older, the incidence of CBD stone also increases.
Yeah, so this question which Dr. Desai pointed out, that if you have painless progressive jaundice, and there are other features to suggest that this could be malignant surgical obstructive jaundice. As I did mention, that the commonest causes of painless progressive jaundice are periampullary carcinoma and cholangiocarcinoma. But GBC neck, which is infiltrating the common duct, common hepatic and common bile duct, and a small tumor can also be painless, unlike body and fundus. Now, there is no evidence, nobody has actually analyzed all patients with painless progressive jaundice, that which is more common, GBC neck with CBD involvement, because it is so common, versus a periampullary carcinoma or a mid CBD cholangiocarcinoma. But I would agree with Dr. Desai that at least in northeast and western part of the country, probably if you take 100 patients with painless progressive jaundice, probably GBC neck with CBD involvement would be more common than periampullary or cholangiocarcinoma. So you should start, based on the history, you should start by saying that this is surgical obstructive jaundice, and considering the age, considering the fact that this is painless progressive and associated with anorexia and weight loss, my diagnosis is malignant surgical obstructive jaundice. It is unlikely to be CA head pancreas because there is no pain. It is less likely to be CA gallbladder, especially fundus and body. But it could be periampullary, it could be GBC neck, it could be hilar cholangiocarcinoma. Now, in response to what Dr. Desai asked about benign causes, if you are asked by the examiner, you should say that the commonest cause of benign surgical obstructive jaundice is CBD stone, which I would not like to consider because there is no history of pain and this is progressive jaundice. However, certain benign conditions can cause what looks like progressive jaundice because the history is short, 4 weeks only. So for a short period of time, even benign obstruction can look like progressive. It is that after some time, the jaundice will come down and may come again. Okay. Yes. And the point about Mirizzi, which Dr. Desai mentioned, in Mirizzi, because the stone, which is actually in the GB neck or Hartmann's pouch, is either compressing or has fistulated into the common bile duct, and it is impacted, it may not cause pain. And it may cause progressive jaundice at least for some period of time.
So moving on to the examination, my patient is cautious, coherent, moderately built and nourished, with BMI of 21 and ECOG of 0. She can climb 2 stairs of flight of 2 stairs. She is ecteric and the scratch marks are noted on upper limbs and trunk. However, there is no pallor, pedal edema, left supraclavicular lymph node, lymphadenopathy, cyanosis, or clubbing. She is vitally settled with pulse of 88 BP of 108/74 with saturation of 98% on room air, and she's afebrile with respiratory rate of 18 per minute. On local examination in the abdomen, on inspection, abdomen is flat with central umbilicus and inverted. Scratch marks are seen over the abdomen. However, there is no visible fullness or lump All quadrants are moving equally with respiration. There is no dilated veins or sinuses. The hernial orifices and external genitalia were normal. On palpation, the abdomen is soft, non-warm, non-tender. Liver and spleen are not palpable. GB is not palpable. Hernial orifices are normal. On percussion, liver span left mid-clavicular line of 14 centimeter. No ascites, tympanic note hurt all over the abdomen. Auscultation, normal bowel sounds, no bruit. On per rectal examination, yellow colored fecal staining is present. However, there is no nodularity or mass. That is, no presence of Bloomer shelf, no blood or black pigmentation.
In the history, did she say clay colored stools? I forgot.
Yes, sir, I have mentioned.
But you are saying yellow colored fecal staining now?
But stools are, yes, on examination.
So there is a contradiction.
Yes.
Because whenever there is a contradiction, you will have to explain it.
Yes. On systemic examination, it was unremarkable. Respiratory, CNS and CV system were normal, sir.
So what is your diagnosis? How does the examination help you? Has it helped you or does it change your diagnosis?
Sir, on examination, sir, there were gallbladder was not palpable, sir. So it aided me in a way that the patient may have a distal a proximal obstruction in case of malignant obstructive jaundice, and distal obstruction can be ruled out in a way because otherwise GB will be distended, which may be palpable in turn if there is a distal CBD obstruction or a periampullar malignancy.
So all patients with distal CBD obstruction will have a palpable gallbladder?
No, sir. That is not. If there is complete obstruction, they may have palpable GB, but if in case of incomplete obstruction, GB may not be palpable, sir.
So any physical sign would not be present in all patients. If it is there, suppose the GB was palpable, then you could have said that it is more likely to be periampullary because here it has been less progressive jaundice, or it could be GVC neck, where again GB will be distended. It could even be mid-CBD cholangiocarcinoma, which is obstructing the cystic duct, but it rules out a hilar cholangiocarcinoma. So if a finding is present, it may make a diagnosis, it may rule out certain diagnosis. But if a finding is not present, it doesn't mean that it can. Not every patient with periampullary carcinoma or cea head pancreas will have a palpable gallbladder. So the absence of a sign doesn't rule out a diagnosis. Same as in the history. Many students say that because there is no anorexia and weight loss, it is not malignancy. That is not true. If anorexia and weight loss are there, it is likely to be malignancy. But if it is not there, it doesn't mean that it cannot be malignancy. Same holds true for the physical signs also. So what you should say that the gallbladder is not distended or not palpable, which to some extent rules out or points that it may not be distal biliary obstruction, but it cannot be completely ruled out.
Milind, what is Courvoisier's law and what are its exceptions?
So, Courvoisier's law states that if a GB is palpable, then it is seldom due to stones. It is generally due to obstruction. The exceptions are, sir.
So the correct description is in a patient with surgical jaundice, if the GB is palpable. At that time, there was no ultrasound. Now you can say if the GB is palpable or distended. If the GB is palpable, it is unlikely to be stone disease. That's all. He said only this. Probably what he meant was, in addition, that it is more likely to be malignant obstruction. But this is what he said. Now the exceptions?
Sir, exceptions are, sir, GB neck, double stones, one impacted in the neck and on the CBD, sir. Secondly, sir, there is a Mirizzi syndrome, which is one of the exceptions, sir.
So in Mirizzi, GB will be palpable?
Sir, if it is cystic duct is obstructed and as well as CBD is obstructed, then the GB will be palpable at that time.
Yeah, but usually Mirizzi syndrome, because it is a manifestation of long-standing stone disease and chronic cholecystitis, usually the GB is contracted, thickened, shortened. It is usually not distended. It is only the cystic duct stone impaction with CBD stone. So CBD stone is causing jaundice and cystic duct stone impaction is causing a mucocele. Mirizzi, usually GB is not distended.
And mucocele of gallbladder, sir, in that cases there is no stone and it may cause
No, but simple mucocele of gallbladder patient will not have jaundice.
With obstruction, sir.
cystic duct stone and CBD stone. That is because Courvoisier initially talked about stone disease, that is the primary exceptions, that cystic duct stone and CBD stone, because indirectly he meant that it is a lower end block. At that time, probably they were not even aware of gallbladder cancer because it was not seen in the West. But we know that it is not necessary that the block is at the lower end. It could be in the cystic duct or neck of the gallbladder also. And same way, a mid CBD cholangiocarcinoma also.
So on the investigations front, we have a blood profile, sir, with a hemoglobin of 11, sir. Counts are normal, sir, uh, which is ruling out any cholangitis at present, sir. The bilirubin is raised, which is 18.2, suggestive of again obstructive jaundice. However, enzymes are AST is slightly elevated 63, ALT is within normal range 58, alphos is elevated twice, range 214, sir, and albumin is normal. However, PT-INR and rest of the liver functions are also normal. So based on the liver profiles, on the blood profile, sir, I can say that patient is not in any cholangitis at present, sir. His counts are also normal. It's just she is suffering from obstructive jaundice. That is what I can make out through the.
Could this be hepatitis?
Sir, in hepatitis, sir, the transaminases levels are way too high, sir. They're in viral hepatitis, they may be in 500s to thousands. Here, the transaminases levels are within very normal range only, mildly elevated, sir.
Yeah, but this is 4 weeks history. Yeah. I don't know what the LFT profile is at 4 weeks after onset of jaundice. Whether the
also,
enzymes.
Can it be stone disease? Can it be CBD stone disease?
It can be, sir, passed out, but sir,
not passed out. She is jaundiced.
Is jaundice, sir.
She has yellow colored stools on finger staining.
Yes.
She has raised AST-ALT, which could indicate an acute obstruction. So why not an impacted CBD stone?
Sir, it can be.
It will be painless.
Yes, sir. It can be a possibility is there, sir. But considering the patient doesn't have any pain and associated loss of appetite and weight.
You said unquantifiable weight loss. In 1 month, you will not get quantifiable weight loss.
Yes.
And second thing is, she has surgical obstructive jaundice. She is itching, and she will have some amount of anorexia because of the jaundice itself.
Yes, sir. So I cannot rule out completely, sir. But
you need to include it in the differential because as an examiner, they are going to see whether you have considered all possibilities and you are not biased. Right. If you stick to one diagnosis, they will get the impression that you know the diagnosis.
Right.
What we want you to do is argue out your case. We want to hear your arguments because we want to see the process which you're following to make a diagnosis. Please go on.
So next, I'd asked for ultrasound abdomen, sir. Based on ultrasound abdomen, sir, liver is fatty with bilobar IHBR is noted. There are multiple GB calculi which is noted with GB wall thick with wall thickness of 5 mm. CBD is normal in size and caliber with 7 mm in diameter. Pancreas is normal. There is no evidence of any free fluid, sir.
So based on this ultrasound, what diagnosis do you make?
Sir, based on this ultrasound, it has to be a high block because CBD is normal. So the block would be above the around the confluence or above the confluence, sir. Secondly, sir, GB wall is thick. However, they have not mentioned anything about whether the wall thickness is regular or irregular, sir. So I cannot comment on that, sir. Secondly, sir, pancreas is normal. There is no evidence of any ascites or any lymph node enlargement that I mentioned. Any masses have not been mentioned. So more likely, sir, it has to be a hilar block which is causing this obstructive jaundice in this patient, sir. It may be due to, because GB wall is thick, it may be due to carcinoma gallbladder which is causing the hilar block, or it may be a hilar cholangiocarcinoma.
So what is missing in this ultrasound report?
Sir, they have although the site of block because IHBR noted the site of block is clearly not mentioned, sir, in this.
Yeah, that's the most important. See, on ultrasound is a very good investigation to delineate the site of biliary obstruction. So ultrasound should show till what level the ducts are dilated. IHBR dilated means that it is obstructive jaundice. They should say whether confluence is formed. Then they should say if the confluence is formed, whether any common hepatic duct stump is seen. Because if the common hepatic duct is seen and below that the CBD is not dilated, that means it is a mid CBD obstruction. They should say whether, of course, they have mentioned that CBD is normal in caliber. So the only thing we can say is that it is not a lower end block. It is not a periampullary carcinoma. It is not a pancreatic carcinoma. But this ultrasound report is incomplete to tell us whether or what is the level of block. Also, if it is mid CBD block, then clearly it should be mentioned whether there is a single large stone sitting at the neck of the gallbladder, the point which Dr. Desai was saying. Could it be a Mirizzi syndrome? So the classical finding of Mirizzi syndrome will be a large stone in the neck of the gallbladder, intrahepatic biliary radical dilatation, confluence formed, common hepatic duct dilated, but distal bile duct is either not seen or is normal in caliber.
What is the association between gallbladder stones and carcinoma of the gallbladder? I will say that carcinoma of the gallbladder is caused by CBD, gallbladder stones. How will you defend it? How will you counter it?
Sir, in a patients with gallbladder stones, the chances of GB cancer are 0.1%, sir. But however, in vice versa, in patients of gallbladder cancer, the incidence of gallbladder stone is very high, sir. I cannot recall the exact amount of value, sir, but it is one of the etiological factors. However, sir, GB stones, the GB stones presenting or masquerading in considering it may turn into malignancy, the number percentage is very less, sir. So I will defend it by saying that this may not be the cause which may cause gallbladder cancer. It may be one of the etiological risk factors, however, but it is not the cause that it may not be the cause that causing gallbladder cancer, sir.
There is also data from Scandinavian countries saying that once laparoscopic cholecystectomy started, the incidence of carcinoma gallbladder fell, which is quoted as one of the reasons why gallbladder stones may be associated with gallbladder carcinoma and are not causative. But Pima Indians have more stones, more carcinoma gallbladder. South America, Brazil, more stones, more carcinoma gallbladder. So even in the north, more gallbladder stones, more carcinoma gallbladder. So there is a definite association, and it's a strong association.
Yeah, so your answer should be using these words which Dr. Desai said, that gallstones are the strongest known risk factor for causation of gallbladder cancer. But it doesn't mean that gallstones cause gallbladder cancer and gallstones cause gallbladder cancer in everyone. Now, nobody knows that how many patients with gallstones, when they are followed up for a long period of time, will develop gallbladder cancer, at least in India, because there are no prospective cohort studies. But if you operate upon 100 patients with gallstones, you would find incidental gallbladder cancer in anything between 1 to 3% of cases. And the percentage of patients with gallbladder cancer who have gallstones in India, in various reports, it is around 60, 70, 75%, not 100%. So there are 20 to 30% of patients with gallbladder cancer who do not have gallstones.
So the patient underwent a triple phase CT scan, sir. This is the portal phase. So the liver is normal, sir. This is the portal phase. We can see the peripheral dilatation of biliary radicals proceeding towards the central dilatation. There is enhancement of CBD, lower CBD also with the wall thickness that is present in the GB. There is air in the gallbladder also that can be seen. Sludge or GB stones can also be noted in the gallbladder, sir. However, intraparenchymal CBD seems to be normal, sir. So just take it slowly.
What do you mean intraparenchymal CBD? There is no CBD intraparenchymal.
I mean, suprapancreatic
pancreatic parenchyma.
Yes, as we can see the biliary radicals that are dilated there. However, portal vein seems to be free.
You have to demonstrate that enhancing wall of the CBD.
Yes,
so
yes,
start
yes.
from the confluence, show the common hepatic duct, show the common bile duct, show up to what level it is dilated and beyond which it is normal.
Sir, so you can see the CBD is getting formed here, sir.
Loud. Many people are online.
So there is, as we can see,
stop
sir.
Here, stop
Yes,
here. Just where it is enhancing. Show that enhancing wall of the CBD.
So here,
So even the GB neck
is
thickened and enhancing, and the CBD wall also is enhancing. This is mid CBD. Below.
In the scan, you can see when the left hepatic duct joining the right duct, where the enhancement starts. You follow
Go
the
up.
CT scan, go up.
Still it is enhancing.
Yeah.
Still.
Go up,
Yes.
enhancing, go up, enhancing, and right. Right, it is also
Even here it is enhancing.
right.
This is just the formation of the confluence.
Left duct is not enhancing, but the right duct is still enhancing. And then they forming the confluence, this confluence also enhancing.
So you mentioned about portal vein. See, you should come to the vessels after you have described the lesion. First, you have to tell us where the lesion is. So the lesion here, the enhancing wall, is, as Dr. Anand was trying to show you, starting from the right duct at the confluence, then the entire common hepatic duct, the mid CBD, and the GB neck. Now go to the intrapancreatic CBD, what you said looks normal. Show the normal intrapancreatic CBD, which is neither dilated nor the wall is enhancing. So let all students appreciate that. So go little up, point out the normal CBD in the pancreas, which is normal in diameter and no enhancement, as compared to the proximal CBD and mid CBD, which was enhancing. The wall was enhancing. Now you describe the vessels in relation to where you see the lesion.
So the portal vein seems to be free in this portal venous phase, sir, from the tumor, sir.
Show the main portal vein, then show the right and left.
This is the main portal vein, sir.
Go up.
And slowly disturbing now, right?
That's the right posterior.
Vein, right?
That's the right anterior.
And this is the left.
And the left
portal vein. Yes. So this is the.
So what is the CT diagnosis?
So based on this, I would say that it more likely to be a carcinoma of gallbladder GB neck, which is causing the hilar block in this patient, sir. However, I cannot rule out whether there is, because there is thickening and there is enhancement that is present up to the distal CBD. So whether it is an extension of the disease or
enhancement is not extending into the distal CBD. Beyond probably the cystic duct junction, it is not. So it is most probably a lesion in the GB neck, which is involving the common hepatic duct. You can't say hilar block because confluence is formed. It is not truly speaking a hilar block. It's a mid CBD block.
I had one question for you, Milind. You didn't explain the air in the gallbladder.
Yeah.
What are the possibilities for air in the gallbladder?
Sir, it may be because of a stone which has breached the wall of the gallbladder, because the patient presented with gallstones are present, sir, which may have sealed out promptly, sir. Secondly, it may be due to any gas formation.
No, but why would you get air if it has just penetrated the wall?
Theoretically speaking,
you would suspect a cholecystoenteric fistula, either with the duodenum or with the colon. That is one possibility. Second possibility is gas-producing organisms causing cholecystitis. It's an obstructed gallbladder. There is cholecystitis. There is gas-producing organisms. Third possibility is there was an intervention. They either underwent EPT in the past, or they underwent stenting at the present, and that's why there is air in the gallbladder. So air in the gallbladder is a very important thing here. Because if you have got a cholecystoenteric fistula, what happens to the lymphatic drainage of the gallbladder?
Sir, if there is cholecystoenteric fistula, then the lymphatic drainage of the gallbladder will, there will be a spread of the disease that is faster compared to if there is no fistula, sir.
See, it can involve the colon or the duodenum. So you should be ready to have that surprise that you're seeing some thickening of the duodenum or of the the colon, and the colon is adherent while you're trying to resect. You should suspect difficulty with the colon. Yes. Second thing is gallbladder drainage will start occurring into the colonic lymphatic drainage bed. So you have to check the lymph nodes in the mesocolon when you're doing a radical dissection, if you're planning a radical dissection.
So since you showed air in the gallbladder, you should show the duodenum and colon also, and show its relationship to the suspected lesion in the gallbladder, whether there is any adherence of any of these organs to the gallbladder neck. Go
And
back.
sorry, sir. Yeah, please go on. And the other thing is that if there is a cholecystoenteric fistula, that is one of the risk factors for gallbladder carcinoma and cholangiocarcinoma.
Yes, sir.
You come down, you will see the duodenum.
Yeah.
Now you
There
start.
is.
That's the duodenum.
Yes.
Yes.
So I think it is not involved, but I think fat planes are.
But there's no fat
Fat
plane
planes are
here.
loss of
See,
fat plane is seen.
At this place,
Yes, sir.
now you see some fat plane, but go a little higher up. Yes, here the wall of the pyloric antrum and duodenum is very close to the gallbladder.
Yes.
You don't see any fat. Come little down, then you start seeing little bit of fat. Here you can see.
Yeah,
Yes.
there is fat plane
Yes.
visible here.
And show the colon. So CT is not a very good investigation to show whether duodenum or colon are involved.
This is the arterial phase, sir. To check regarding the arterial anatomy, whether there is involvement of any arterial.
Trace the artery from the celiac. Yes. Start tracing.
There is replaced right hepatic, sir. Yeah.
So which artery is more likely to be involved here?
It has to be right hepatic.
Right hepatic. Because it is related to the common hepatic duct, so whether behind or in front.
So it is replaced from SM actually here, and it seems to be, sir, free from the tumor. However, I think there is.
How do you describe the involvement of vessels by a tumor on CT scan?
Sir, it can be either encasement or abutment, sir. Abutment means less than 180 degree of involvement. If there is encasement, that is more than 180 degree of involvement. However, if there is, we have to check whether there is contour deformity also which is associated with the tumor abutment or not, sir.
So you should say that normally most vessels will be round or maybe oval in shape. They will have a smooth outline, regular. The diameter, depending on whether you are dealing with an artery or vein, from proximal to distal, will either increase or decrease proportionately. In a well-built patient who is not cachectic, who is not severely malnourished, there will be a fat plane between the vessel and the tumor. Now, so first feature is absence of fat plane, but absence of fat plane may be there because of no fat being there in the body. If the patient's BMI is very low, patient has lost significant amount of weight recently, there may not be a fat plane. So first is absence of fat plane. Then there is the angle of contact between the vessel when seen in cut section and the tumor, which if it is less than 90 degree, it is said that vessel is not involved. If it is 90 to 180 degree, it is described as abutment, which means suspicious involvement. If it is more than 180 degree, it is considered as involvement. Then there could be complete encasement, that the vessel is running through the tumor. Then there could be alteration of shape. Rather than being rounded and oval and smooth outline, it becomes irregular, it becomes altered shape, the teardrop appearance. Or proximally, the lumen is all right, distally, the lumen is all right, but in between segment, it is smaller. That also is an indication of involvement. Complete absence of the vessel, you don't see the vessel at all, that also, and a thrombus in the vessel. So these are various radiological findings which indicate whether the vessel is likely to be involved or is involved. Complete encasement, more than 180 degree, thrombus, complete occlusion, alteration in shape, these are definite features of involvement of a vessel.
So the CT report was suggestive of the cholelithiasis is seen. There is diffuse mild gallbladder wall thickening seen predominantly in its cystic duct neck region involving the adjacent common hepatic duct extending up to the biliary confluence and adjacent suprapancreatic CBD, causing marked luminal narrowing with dilatation of bilobar IHBR. Small air pocket is also seen within the gallbladder lumen. There is loss of fat planes of the mass lesion with the portal vein. No intraluminal thrombus or invasion is, however, seen. Replaced original right hepatic artery is seen from superior mesenteric artery. There is loss of fat planes of mass lesion with adjacent right hepatic artery, which, however, appears well opacified. Celiac artery is normal. Left hepatic artery is normal in course. There is loss of fat planes of thickening seen in fundal region of gallbladder with hepatic flexure of colon. Fat planes with proximal duodenum also appears to be lost. The CBD along its pancreatic course.
So they are saying there is thickening in the fundus
also. Yes, sir. CBD is along its pancreatic course appears normal in caliber. Lymph nodes are seen in periportal, portocaval, and aortocaval regions, with the largest being 6 to 7 mm in short axis. Liver is showing relatively hypertrophy of its caudate lobe. Hepatic veins are normal. Intrahepatic portal vein branches also appear well ossified. Multiple variable size soft tissue attaining nodular lesions are seen in lower lobes of bilateral lung, one of the largest in right lower lobe, measuring 7 by 6.3 mm in size. So looking at this CT scan, I would like to proceed with a PET CT scan in this patient. I would want to know if there is involvement, any diffuse metastasis is present. Also, I'm concerned about this lung lesion. So I would want
Do
to
we see the lung lesions on CT? Could we appreciate them?
Yes, it is there in this, I think, with the PET film.
So you want to do PET for what?
To assess for whether the patient is having any distant metastasis, which renders him
Distant metastasis where?
unresectable. It may be in the lungs, sir. It may
So
be.
you should say that the lymph nodes which are seen on CT do not look significant because they are small. But the lung lesions, she was a non-smoker.
Non-smoker.
So all the more that if you are saying parenchymal lesions on CT scan, that yes, you would like to delineate on PET scan. So PET is not for diagnosis. PET is for looking at extra-abdominal disease.
Does she have any history of reflux?
No, sir. She did not give any other histories of reflux.
Because even that can produce nodules in the lower lobe of the lung, which can be mistaken for metastasis.
Yes,
so when all the lymph nodes are so small, you should go back to the history and check whether she has any difficulty with the GERD. Because whether choking attacks, GERD, if there's any such thing, then it would support a possibility that it could be just a benign nodule and not a malignant nodule.
Yes. So based on the PET scan, sir, as you can see, there is minimal uptake in the lower regions of lung. However,
no, but I think there was a large subpleural.
Yes, deposit is there. Yes,
yeah,
this one. So according to that AVDT, it has to be uptake should be more than 5 to be considered as malignant for in our institute.
So how much was this?
I think 4.3 it was, sir.
But
so it is still suspicious, sir. Secondly, sir,
and more so because they are subpleural.
Yes.
Subpleural nodules are very typical of metastasis.
So as we proceed, there is uptake in the GB wall, but the uptake is not, sir. It's not a high uptake of a PET scan, sir.
So gallbladder doesn't show.
From the enhancement, there is mild uptake, but it doesn't show. It is
what
not.
Was the SUV?
SUV max was, sir. Gallbladder was 4.7, sir. Same, yes, around about the same type of lesions, sir. There is no elsewhere uptake in the parts of the body.
To the best of my knowledge, cholangiocarcinoma and carcinoma gallbladder doesn't have a high SUV max.
Yes, they are not, sir.
As compared to pancreatic.
So the report is low grade FDG uptake with minimal enhancement in neck of gallbladder and intraluminal mixed density if you calculate partially distended gallbladder without any obvious wall thickening and pericolic fat standing. Likely low grade FDG have multiple pleural based and parenchymal fibronodules at bilateral lung fields as described above. They considered they may be infective. They needed a follow up, sir. There is mild to moderate fluid independent part of pelvic cavity. Otherwise, rest of the study was normal, sir.
So based on CT and PET now, what do you think it could be?
Sir, based on CT and PET, it still could be a carcinoma of gallbladder invading the common hepatic duct, sir. Or it may be hilar cholangio, which may be extending.
Hilum is not involved. You can't say hilar. You can say cholangiocarcinoma. You can't say hilar.
Sorry, cholangiocarcinoma.
Cholangiocarcinoma, the hallmark is that the confluence has to be involved. That is not there. So what I'm trying to hint at is that after seeing these two images, you should start mentioning whether it is an inflammatory condition. Xantho, especially because the uptake is low. Sometimes even in xantho, the uptake may be high, and it may be very difficult to differentiate between xantho and GBC. And as Dr. Desai said, in GBC and cholangiocarcinoma, the avidity or the SUV is not as high as in pancreas. That is why in pancreas it has become almost a routine. But still it is high. And if you see low avidity, low SUV, and a picture like this, you have to start thinking whether it could be a xanthogranulomatous inflammation, which is virtually impossible to differentiate from CAGB. Usually it is diffuse, the gallbladder involvement, but focal xanthogranulomatous cholecystitis is a known entity, and it can infiltrate adjacent organs like GBC. Even at surgery, even in the specimen, it can look exactly like GBC. It is only histology which will tell you that it is not malignancy. Any other investigation which can help?
Sir, I would like to, although the avidity of the nodules in the lung fields are very low, I would still like to get a biopsy done of this lung nodules. From the lung nodules, transbronchial biopsy, I think can get. Because it is
How
the
would you
lower.
get the biopsy?
Sir, the subpleural deposits can be biopsied using, I think, sir, under CT guidance, sir.
Yeah. You wouldn't say bronchoscopic guided. That's an
No, no.
important thing.
Yes, sir.
You would do a CT guided. But
guided biopsy.
it's subpleural and it is small. The likelihood of hitting it accurately in a moving lung field, I think, is very low. So thoracoscopic biopsy might be a better approach if you are still considering a radical resection for this case and you still
And-
think it is malignancy.
Sir, and secondly, sir, we can go for a left-sided PTBD, which would help us in two things. One is that it will suddenly decompress the biliary system, and secondly, sir, we can follow up the patient after the 2 week when the patient is free from jaundice in this patient. And thirdly, while planning resection, also left PTBD is going to be useful in this patient because it will help us in identification of that, sir.
So there's no other way that you can get a tissue diagnosis other than the oral biopsy you mentioned?
USG guided, sir, I can get a gallbladder biopsy, sir. But I would not, because considering we have not ruled out the patient is having.
Have you done endoscopic ultrasound? I think endoscopic ultrasound guided brush or endoscopic ultrasound guided FNAC might be a possibility.
Since the CBD is involved, you have to mention cholangioscopic diagnosis. Now you have cholangioscopy available. You can, even if you don't have a cholangioscope, you can try a brush from the CBD. These are all answers. The yield may not be good, but these are possibilities. You can even do bile cytology at the time of endoscopy. And why PTBD? Because here the confluence is patent. So even an endoscopic drainage is an option. So at the time of endoscopy, you can get bile for cytology, you can do breast cytology, you can do cholangioscopy where you can directly visualize the CBD and take a brush or even biopsy from there. And ultrasound guided biopsy or FNAC from gallbladder will be the last resort. You don't want to do it, especially if there is no mass lesion seen. So suppose you can't establish a tissue diagnosis, suppose all this is negative. You have done all this, you don't see anything.
So then I would first decompress the biliary system and then plan her for resection, sir.
What resection?
Sir, the planning would be I would plan is as if the patient is having malignancy. So my plan would be a modified extended.
So your first answer should be that since the radiological suspicion of malignancy is high, malignancy cannot be ruled out. A negative tissue diagnosis does not mean that it is not malignant. So I will treat it as malignancy.
So, sir, the plan of the surgery would be a modified extended right hepatectomy with removal of segment 5, 6, 7, 8, and 4B, sir.
Why hepatectomy?
Because, sir, considering it is a carcinoma, the primary suspicion is a carcinoma gallbladder involving the common hepatic duct, sir. So, a radical resection is warranted in this patient.
So, if it is GBC neck involving the common hepatic duct, the patient should have a right hepatectomy?
No, sir. There is also, sir, loss of fat planes with right hepatic artery as well as the right portal vein in this patient, sir. That we see.
That may be
You can reconstruct.
Inbuilt. She's lost weight. What was her BMI?
21.
So low on the lower side. As we discussed earlier, loss of fat plane doesn't mean that the vessel is involved. The reason is what Dr. Anand pointed out. that
You
the
can do a
thickening is
mid
extended
CBD
into the
resection.
right duct.
Right.
So
You
it is
can do
very
a CBD
unlikely that you will
resection.
get a
Yes, sir.
You can do a radical cholecystectomy with CBD resection, but you would prepare for reconstruction of the portal vein and the hepatic artery.
Yeah, actually, Anand pointed out that the thickening of the enhancing thickening of the CBD and CHD is extending into the right duct also, and that is why Anand was of the opinion that we may not get a clear margin on the right
Okay.
duct, as it is
That
the
makes
right
sense.
duct.
But if this is seeming more and more like a papillary form of gallbladder cancer, it's an infiltrative kind of growth in the CBD wall and in the proximal CHD. So in this, you get what you call mucosal spread, and mucosal spread can be seen both in CAGB and in cholangioCA. And
So
this is more in support of CAGB rather than cholangioCA.
I don't think looking at the CT that the right hepatic artery and right portal vein are involved, but definitely that enhancing thickening of the right hepatic duct is suspicious. You could, and at the level of the GB neck, there is no direct liver infiltration. So these are cases where an extended or a radical chole with CBD excision is an option. But considering that finding of right hepatic duct involvement, if at all first you are doing this, you will have to look at the margin, especially of the right duct. And here CBD excision will go right till the confluence so that the two ducts are separated. And in all likelihood, that margin may be positive, and that is why you have to be prepared for a right hepatectomy. So, reasons for right hepatectomy in gallbladder cancer could be one, involvement of the right hepatic artery and right portal vein, even if the tumor is small and in the neck. Second, if the tumor in the neck is infiltrated the liver. Now, once liver is infiltrated, you know that the right pedicle lies only at a distance of a few millimeters. So you can't get 1 centimeter margin there. Third, it could be a large tumor in the fundus and body, which extensive infiltration in the right lobe of liver. All segments of right lobe are involved, and you can't get a margin even with 4B and 5. So, perforce, you have to do right hepatectomy. And lastly, it could be something like this, because whether this is GBC neck with involvement of right duct or whether it is a cholangiocarcinoma with involvement of GB neck, and in that case, a right
अम्मा को
hepatectomy
फोन करके पूछो आना क्या बोल के बाहर जाते कि क्या है क्यों ना.
is the treatment of choice. So those are the reasons which you should say you will need a hepatectomy probably. And in a case like this, where you're doing a major surgical procedure with definite risk of mortality and high morbidity with negative tissue diagnosis, with a suspicion that it may turn out to be benign, you must at some stage mention counseling and consent process, which is very, very important. You have to explain to the patient that ultimately the histology is benign and unfortunately there is a mishap, then you have to be prepared for that eventuality, both ethically and legally. Thank you. Thank you, Rajen.
Thank you, sir. Very nice discussion today. Interesting case.
So, see, as he was saying, that it is not the answer, it is the justification.